Hello and welcome once again to APHA's 15 on COVID-19 series. I'm your host, Dan Zlot, Vice President of Education for APHA. Today we're going to talk about a question that we have received many times, and that is the ability of patients to develop antibodies against COVID-19, as well as a quick look at the possibility of reinfection with COVID-19, certainly a topic that's been in the news a number of times. So without further delay, let's go ahead and jump in. One of these days I may surprise everybody and have something to disclose, but that day is not today. For today I have nothing to disclose. Here are your learning objectives for today's episode. All right, now before we jump into some of the specifics about whether we can develop antibodies against COVID-19, I thought it might be helpful just to briefly review the process of how we develop antibodies in general. So antibodies are produced by activated B cells, which are also called plasma cells. So you'll hear those used interchangeably. B cells recognize their targets through immunoglobulins that are present on the cell surface. And it's important to understand that each B cell has one single immunoglobulin that it produces, and also one single immunoglobulin that's mounted on the cell surface. And those things are often one and the same. So that's how B cells see the world, is sort of through that surface-mounted immunoglobulin. And so that's the first step in a B cell becoming activated, but it's not the only step. So the other piece of B cell activation is that a helper T cell or a CD4 positive T cell needs to come along and essentially activate the B cell. So the way that they do that is that once a CD4 helper T cell is activated, they secrete pro-inflammatory cytokines, a number of interleukins, IL-6 for example. And so once that signal hits the B cell, in addition to the B cell recognizing its target, the B cell can become activated. Now, once they become activated, B cells can do one of two things. They can become a plasma cell, or they can become a memory B cell. Plasma cells, as we've already discussed, they secrete usually large quantities of whatever antibody they produce. Memory B cells sort of stick around, and when we're re-exposed to a particular antigen that we've developed an immunity against, they start to multiply, and they will trigger the activation of plasma cells to produce antibodies against that antigen. That's how we remember the things that we've seen in the past and how we mount an immune response much more quickly than we did the first time around. Now, again, each plasma cell makes a single type of antibody against a particular antigen. And in general, there are 5 classes of antibody, and so they're here in the photo for you, but just to list them, we've got IgA, IgD, IgE, IgM, and IgG. Now, for the purposes of today's discussion, we're really going to be focusing on IgM and IgG. Those are the two antibodies that are of most relevance to us. The other antibodies are either not well understood, or they don't really have a significant amount of application to what we'll be talking about today. So, one other thing that's important to understand is sort of the time frame. So once we're exposed to an antigen, we don't start making antibody right away. There's a little bit of a delay. And so this photo here is actually a response curve taken from dengue fever, not so much COVID-19, but you'll see a little bit later on that the curves look somewhat similar. So typically, we think of IgM as the initial antibody produced when we're exposed to a pathogen for the first time. The IgM starts to show up usually 4 to 7 days after we're first exposed to a particular pathogen, and it tends to peak 7 to 10 days after initial exposure. After that, as you can see, it will hang around for 2 to 3 weeks, and then it starts to fall off relatively quickly. On the other hand, IgG is sort of a longer-term antibody, and it's also produced upon initial exposure, but it takes typically a little bit longer to show up. However, once we've developed IgG antibodies, that is the antibody we produce upon re-exposure to the same antigen. So again, that's sort of where that idea of long-term immunity comes from. Now, IgG appears 7 to 10 days after initial exposure, so again, it's a little bit later, and then it tends to peak 10 to 14 days after initial exposure. So again, the peak is a little bit longer. It will hang out for a little bit longer. Eventually, the level of IgG will fall, but because of those memory B cells that we talked about on the last slide, upon re-exposure, they get activated, they activate plasma cells pretty quickly, and then we start secreting IgG in rapid fashion to help control or prevent an infection. So now that we've gotten a quick review in B cell immunology under our belts, let's talk about the real question at hand. Do people generate an antibody response to COVID-19? And the short and sweet answer is yes, absolutely. So this is a study that was done in China. So this is a cross-sectional study from 3 different hospitals, and it included about 285 patients. And what they found was that 100% of patients developed either IgM, IgG, or both within 19 days of COVID-19 symptom onset. Now, if you look at the graph, you may notice that there's actually a higher incidence of patients who developed IgG as compared to IgM. And so it's a little bit difficult to interpret this. One thing to note is that the time scale is a little bit different. So this graph is showing days after symptom onset. The graph we looked at on the last slide, which talked about time to IgM and IgG production, was talking about days after pathogen exposure. And one thing we know with COVID-19 is that you don't necessarily develop symptoms the instant that you are exposed to COVID-19. So there's a delay of anywhere from 2 to 14 days from the exposure to the onset of symptoms. And so during that time frame, if our immune systems are doing what they're supposed to be doing, we're starting to develop an antibody response. And so I think that's probably the reason why you see a little bit of discrepancy in the time course between IgG and IgM. Now, it's important to note that all patients included in this study were confirmed to be COVID-19 positive by PCR, so we know that they definitely were exposed. And the serum IgG levels were tested by ELISA. And so it's the enzyme-linked immunosorbent assay, in case you're not familiar with ELISA. We did a brief review of ELISA assays in our April 10th episode of 15 on COVID-19, which focused on COVID-19 testing. So if you want to learn more about ELISA, I would refer you back to that episode. So another question is whether or not the antibody response follows the pattern you would expect to see in most infections. So this group took a look at that as well. So the orange boxes here represent IgG, the blue boxes are IgM, and as you can see, the antibody levels increase for about 3 to 4 weeks after symptom onset. Now they didn't go further than that, so we don't know how long the COVID-19 antibodies last, and that's an outstanding question that we'd all like the answer to. However, this fits in with a pretty typical response pattern. Now, if we were to test for longer, you'd expect to see this plateau, and then over the course of 3 months or so, maybe even sooner for IgM, you'd expect it to drop and then basically fall to undetectable levels. So another thing that this group looked at was whether there was any difference between patients with severe COVID-19 disease and those who had mild to moderate disease. So let's take a look at what they found. And there was really only one area of difference, and that was in the second week after symptom onset. So patients who had severe disease had significantly higher levels of IgG as compared to those who had non-severe disease. So again, that's mild to moderate. Now, as you can see, and that was statistically significant. Now, as you can see, there was no difference for the rest of the time frames, and there was no difference in IgM levels regardless of time frame between patients with severe disease and patients with non-severe disease. Now, what exactly that means and whether that has any impact on time to recovery or the severity of disease is unclear at this point. So it's really sort of an observational data point for us. And over time, as we learn more about the immune response in COVID-19 and sort of what our immune system is doing, we may get a better sense of the role, if any, that IgG plays in that immune response. So it's important to note that Similar findings were also observed in other studies. So this study in particular was a study of 173 patients, and in that study, about 93% of patients developed an immunoglobulin response, whether that was IgG or IgM or both, over the course of about 30 days. Now, on the surface, that might seem to be a little bit lower than the 100% we saw in the previous study. However, one thing that the authors did point out is that they had limited sampling after the 2-week time frame, and so they speculate that that may have been responsible for that less than 100% rate. So without that additional data, we'll never know if there are people who don't develop antibodies and what percentage of patients don't develop antibodies. But on the whole, it's a good bet that the overwhelming majority of patients will in fact develop antibodies against COVID-19 if they are exposed. Now, that leads us to our next question. So if we've got antibodies, one of the big questions is how long do they last and do they protect you from reinfection? So it turns out there has been a lot of news talking about reinfection, reactivation of virus. The vast majority of these have been coming out of South Korea, and depending on which paper you read and exactly what point in time, you will read that around 260 people have been quote unquote reinfected with COVID-19. Now, that's in the news, and I generally don't look at news sources as scientific, and certainly don't take them as anything that I would necessarily base clinical decisions on. So what we did instead is we went back to PubMed, we went back to Embase, and we took a look at case reports to see if there were in fact any case reports of reinfection with COVID-19. And if you do that, you will find that there are no case reports of reinfection. There's a number of articles there, but none of them actually describe a true case of reinfection. So then the next thing that comes up is reactivation. So maybe the virus hangs out, it hides away somewhere that our immune system can't detect it and we can't detect it using our PCR assays, and then at some point down the road it reactivates. So there are a couple of case reports of reactivation. So let's dive into one particular case series and see what's to be found there. So this one is a case series that consists of 2 individual cases. So let's go through the first one. So this was an 81-year-old female who was transferred to one hospital from a behavioral health facility on March 9th of 2020 due to fever and cough. She had pretty significant past medical history, which included diabetes, coronary artery disease, atrial fibrillation, and bipolar disorder. Now, she was confirmed to be COVID-19 positive by PCR assay at the time of admission, and her chest x-ray at that time showed infiltrates in the left upper and left lower lung lobes. So definitely some evidence of something on chest x-ray. So continuing on with the first case, what happens is a couple weeks go by and the patient's symptoms resolve over those 2 weeks. Now, a PCR test on March 23rd was performed and it was negative, so no evidence of the virus there. The patient was then discharged on March 24th, the following day. And then a couple weeks later, in mid-April, April 18th, the patient is readmitted following 4 to 5 days of worsening shortness of breath, fever, and confusion. At the time of readmission, they performed another PCR assay for COVID-19, and that was positive. So we had PCR confirmation of COVID-19 at the very beginning of this case. The virus appeared to have cleared, and now it seems to be back again. So that's very interesting. At the same time, a CT scan revealed bilateral pleural effusions, right upper lobe infiltrates, just indicating again that there's some significant chest involvement, pretty consistent with what you would see in COVID-19. And then the patient unfortunately expired on April 22nd after the family made the decision to withdraw care. So that's where the first case ends. Now let's move on to the second case. So in the second case, this is a 77-year-old female who was status post transfemoral aortic valve replacement for severe aortic stenosis, and that took place on March 23rd. Unfortunately, during the procedure, the patient experienced an ischemic stroke, and so she remained hospitalized. And over the course of her hospitalization, she developed cough and fever. And so they performed a PCR assay for COVID-19, and that was positive. The authors don't report the exact date that the PCR test was performed, so we're a little unclear on the time scale there. However, we do know that a chest CT on March 28th was normal, so it looked like there was no lung involvement at that time. And then this patient's clinical course for COVID-19 was pretty unremarkable. So she may have been one of those, 80+% of patients who were infected, but really had no symptoms to speak of. Now, the patient was then transferred to another hospital on April 1st. And at that time, the patient was noted to be afebrile and hemodynamically stable. So again, she continues to be without any significant symptoms from COVID-19. Additionally, before the transfer, just after the transfer, they did 2 consecutive nasopharyngeal swabs for COVID-19, and those were both negative using a PCR assay. So the patient was then discharged to a rehab facility on April 8th. All right, so moving on with the second case. So on the 22nd of April, the patient was readmitted to the hospital from the rehab facility due to a cough that had persisted for 4 days. Additionally, another PCR test was performed, and it turned out that the patient was now COVID-19 positive again. So the patient, over the course of a day or two, developed hypoxemia, and a chest CT at that time showed ubiquitous ground glass opacities with the predominance in the right upper lobe. So again, very consistent with what you'd expect to see in a COVID-19 patient. And the patient was started on hydroxychloroquine and azithromycin along with supplemental O2 therapy. At the end of the report, the patient was still in the hospital in the COVID-19 isolation ward. So that's sort of where the case ends for us. So these are 2 interesting cases. Now, let's talk about some of the limitations. So obviously this is a case study with an N of 2, so it's very difficult to draw many conclusions from this. However, what I will say about this case series is they did a nice job of documenting COVID-19 positivity, COVID-19 negativity, and then COVID-19 positivity again. So that's one of the good things they did. However, what they did not do was rule out other respiratory viral infections. So what we know is that more than 20% of patients, it's about 21% if you look at the literature, of patients who have COVID-19 may be co-infected with other viral respiratory pathogens. And so whether those are, adenoviruses, other coronaviruses, etc., it's not at all uncommon. So without doing some of that additional testing, it's impossible to know if the symptoms that we saw, either in the initial presentation or in the quote-unquote reactivation or relapse, were a result of COVID-19, or if it was a result of some other respiratory pathogen. And so we will just never know. And that's a huge confounder in this case series and really detracts from our ability to say, yes, reactivation is in fact an actual phenomenon that we see, or no, in fact, reactivation is not a phenomenon that we see, and that second case was due to a flu virus, or that second case was due to, a really nasty cold or some other viral, pneumonia or something like that. So that is, to my mind, the huge confounder and really, more than anything else, limits my willingness to say that, yes, reactivation is definitely a phenomenon that we see in COVID-19. Additionally, both patients had significant comorbidities, as we reviewed, another huge factor there. So a lot of limitations. I mean, again, it's a case series to begin with, so we knew we were going to have a ton of limitations as we went into it. All right, so just a couple of additional points. We started off talking about the news stories from South Korea, and so after some additional follow-up from South Korea, those 260 cases that they identified as reinfection or reactivation, they called those basically false positives. So it turns out that their tests were relatively sensitive and were able to pick up viral RNA fragments, and long after potentially the virus was still alive. They may have been just picking up little pieces of the viral RNA, and they think that that's what was causing the false positives. So it's another, monkey wrench in the theory of reinfection or reactivation. So we still really do not know whether or not reinfection or reactivation is possible. So we need more data, and we need people to do thorough examinations and explorations of other causes when it appears that there is in fact a COVID-19 reinfection or reactivation. We need to rule out those other respiratory pathogens as much as we can. So that's, unfortunately, as we have talked about so many times, we still need more data before we can really answer the question of whether reinfection or reactivation of COVID-19 is a phenomenon. And that will wrap up today's 15 on COVID-19 episode. Thank you so much for joining us. Our next episode will be released on Friday, May 22nd, and we will be talking about a subject that has been all over the news in the last day or two, and that is hydroxychloroquine for COVID-19 prophylaxis. We hope to see you on Friday. Until then, if you have any questions about COVID-19, please send them our way. covided@aphanet.org is the email address. Thank you once again for joining us, and we hope to talk to you on Friday.